So with the presenting complaint, that should say history of presenting complaint. So let's not go straight into, so when they tell you they've got this, X symptom, don't jump straight into Fraud Parle, Socrates, or whatever memory aid or whatever closed question system that you're using for exploring a symptom. Make sure you start off with an open question. Again, that's very important. You will lose marks if you don't do that. If you start asking about pain straight away, about where it is as your first question, then that's going to lose you a lot of marks. So you might also, I should probably have included something about an empathetic response if appropriate. So it might be worth, if they've been going through a particularly troubling experience in the last few days or hours, then you might, want to say, oh, that sounds like you've been having a really difficult time. Could you tell me more about that? So that would be a nice way to start the presenting complaint. Then you can go into, let them get it off their chest. They might need even, 30 seconds or so. They won't take too long, so they won't waste too much time. But at the end of the day, that's not time wasted. That's probably not the right thing to say, because they're giving you cues on the things that are important to them. And so this is patient-centered. The agenda is what the patient wants to discuss, not what you want to discuss. So it needs to be, if there's something bothering them, then you should address it there and then. And then, so Fraud Parle, that stands for frequency, onset, duration, progression, aggravating factors, relieving factors, and anything else. Associating symptoms is the last one. And so that's nice because it ends with the associated symptoms, which will blend in nicely with differential diagnosis. So you should always have, when you have a presenting complaint, you should have 3 or 4 conditions there in your head that you should be thinking about. And so throughout your information collection process, you should be kind of rearranging them like to the top of the queue, or bringing them down according to how they respond to certain questions. So I think that's important. What's really important is the red flag. This is often what will fail you in a station, similar to I think it was the safety netting in management. Those 2 points really, really important, because you could have a perfect station, but if you forget those, they can still fail you. So make sure that you're safe, and so you've got those covered. So always have those 2 in mind when you're approaching any case. Risk factors, so if someone's got asthma, you might want to ask about triggers or any allergies and things like that. Relevant systems review. Again, the important word here is relevant. So try to ask about what's, so for example, if a female of reproductive age presents with abdominal pain, then you might want to, or you will have to ask about, gynae symptoms. Again, and also red flags as well here, because we need to exclude a ruptured ectopic pregnancy. So it might be worth, or you will have to ask about when the last, if there's any chance if she could be pregnant, or you could ask when the last menstrual period was, or you could ask, was your last menstrual period any different to normal? Something along those lines. So these stars are, just to point out that these 2 points, you should signpost before you mention these. Don't go straight into asking about smoking and alcohol. You need to signpost it before. So for personal history, if relevant, by the way, there's a reason why that's, in brackets and not in bold, because you're not going to ask this for every individual. This is only for specific cases. So please do not go through asking people about drug abuse after you're presenting complaints for somebody who's just, regular guy who's got, a bit of shortness of breath because he's got heart failure. It's not appropriate. Nevertheless, if you are going to ask them because they are relevant, then you will need to signpost them. So a good way to signpost the personal history section is to say, I'm going to ask you a few questions now that might seem a bit personal, but it may well be related to your problem. And then you can go into the questions. Similarly, for the social history, you could ask, I'm just going to ask you a few questions that might not seem related, but it may help rule out other causes of your symptoms. And then you can ask, do you smoke at all? And then ask. The important one for social history that's often forgotten about is home, because that gives you a lot of valuable information about carers, who's at home to provide support. Also important in pediatric history as well, because of not just for caring for the child, but also for giving you clues about non-accidental injuries as well. So yeah, past medical history, medication history, allergic history, family history. We won't go into any depth in those. I mean, everything's, I'm sure, has been covered over the years, and you've asked patients these questions a lot. But I think the main thing to emphasise is that this is a focused history. You, like Dr. Rana mentioned earlier, you are expected to, to perform a little bit better than someone who's just finished medical school, because you're a level above that. So you're not being tested on just asking all the questions that you need to ask. It's about picking and choosing which ones, because you only have a certain amount of time. So you will not be penalised for missing out travel history in somebody that has an MI or something. It's just not worth your time to ask that, because you've only got 8 minutes. So yeah, definitely ask those only for if it's relevant. The other thing for medication history, don't forget if it's relevant to ask about over-the-counter medication, supplements, herbal remedies, that kind of thing. So not just current medications, not just regular medications. Past medical history, you might want to have some go-to. I mean, some people use MJ threads, which is MJTHREADS, MJ threads. Some people like to use that for just a list of conditions to ask people when you're doing past medical history. I don't know, some of them, MI for M, jaundice or liver problems, TB, hypertension, R for rheumatic fever, E for epilepsy, and A for asthma, D for diabetes, S for stroke. So that's one thing that people often use. But I think better than that is just to ask things that are relevant. I think maybe hypertension and diabetes certainly should ask for all cases. I think.
Why don't you just, I mean, sorry to cut you and interrupt in between, but can we just ask, do you have any other medical problems, or do you have any medical issues that you take medication for, or would that be, or do we have to specifically ask them, are you diabetic, hypertensive, and do you have?
I would start off asking the opening question. But if they say no, I wouldn't necessarily just move on. It may be that they forgot that they, have high blood pressure and they take tablets for it. They might have just forgotten at that point. So I would say, yeah, definitely start with those standard questions that you've been asking. But then you need to, ask them if they've got diabetes or high blood pressure, and then ask them also if there's, if someone's presenting with a swollen, painful calf, you can ask them if they've got a history of blood clots. And then when you get to family history, you can ask them if anyone's ever had any blood clots in the family. So and you can ask them if they've had any previous surgery as part of past medical history. So you might not necessarily ask everyone if they've had any previous surgery, but if someone who's presented with a blood clot recently or symptoms suggestive of a blood clot, then it would be worth asking if there's, if for the risk factors for thrombosis. Does that make sense?
Yes, definitely.
Same thing with allergies. Like if somebody's just going in to have surgery, say they've just presented with what looks like appendicitis, you suspect it's appendicitis, probably going to need appendix, I can't say that word. But yeah, probably going to need to have their appendix removed. Let's just say that. So appendicectomy, yeah. So if they're going to go into surgery, this is dirty surgery, it's gut surgery, so they need to have prophylactic antibiotics. So it might be worth asking, do you have any allergies to any antibiotics? Just specifically, just to show the examiner that you're always focusing on what's relevant. Yeah.
Yeah.
because you know that they're probably likely going to be prescribed antibiotics within the next few hours. So it might be worth asking just to check that off. Family history again. So if somebody, so I would ask, are there any conditions running in the family? So this would be your first grade relatives, mum, dad, brothers and sisters. Oh, the other thing, by the way, is if the patient's uncomfortable, to make sure that you address that straight away. So if they're in pain, the last thing they want to do is, have somebody, a stranger, ask them questions for 20 minutes. So you need to offer them painkillers if they're in pain. If someone's presenting with renal colic or any other acute painful condition, make sure, not just pain, they could be breathless and they might not be able to talk. So you need to establish whether or not, and you need to be aware of your environment to do that. So you need to look, there will be, the actors and actresses will be given cues. So they might be lying down with their head in hands. They might be in obvious visible pain. So you need to make sure you respond to those straight away, and try not to get too bogged down into the structure. I think I did mention about starting with an open question, didn't I? I think for the second time round. So I think that's everything. Just don't forget the red flags as well. ICE is really, really important for the exam, and it's not something you'll find. ICE is incorporated in different structures in different places, and the reason why is because it doesn't really have a place. It's something that you should be on the forefront of your mind throughout the consultation, and you should respond to any cues as and when they arise. So the important thing with ICE is always be on the lookout, because they're really important. If a patient comes in with certain concerns and expectations, you need to address those. If they come in looking with upper respiratory tract infection, and they expect to have antibiotics, so you need to address that. You might not agree that antibiotics are helpful, but you need to explain why. And if you haven't addressed what their expectations are, then you won't know to do that. And I think that's very important. So make sure you do at some point include all three of these different things. One thing examiners don't like, if you use the terms ideas, concerns, expectations as well, because it's a bit too rigid. Just kind of, use more natural language. Try to avoid using the words themselves. Instead of concerns, maybe using worry. Instead of ideas, if you had any thoughts about what the cause of the symptoms may be. Instead of expectations, was anything particular you were hoping. Remember to, might be worth asking this, double checking at the end of the consultation, to ask about expectations as well, just to make sure there's nothing that you missed out with the management plan. So yeah, ICE, remember, just anywhere throughout. If you ignore any cues, then you will be penalised for that. So to make sure you do, it's on the patient. The consultation's on the patient's terms, not on your terms. And then just effects as well, very, very important in consultation skills. I mean, Dr. Rana was talking about this earlier. It's really, really important to emphasize how much it's affecting their ability to sleep, to work, because these are the most important issues to the patient. And this is all, they're really, really big on patient-centered care in the UK, and shared care. That concept is very important. So try not to try to look at things from their perspective, try to be empathetic, and try to work together with the patient to come up with a management plan, as opposed to you telling them what to do. I think that's really important. So just be careful how you phrase certain things so that they don't come across as if you're telling them what to do. And then again, recapping. So recap once at the end of the history, and then once at the end of the management plan, I think are two sensible ways to recap. Try not to recap in a way that's, just recap the important points. And this will also help you structure the presentation in your own head, so to help you think about moving forward what the diagnosis and the management plan is going to be.
Thank you.
I have a question. I'm sorry I joined in late, but may I?
Of course, go ahead. Thank you.
Yes,
okay, so when you talk about focused history, I understand that we're running short on time, but would we know already what the case is? Like, because I have no idea and I've missed the earlier part of this lecture. So would we know what the case is, and what exactly do you mean by focused history?
right. So the idea behind taking a focused history is to pick and choose those parts of the consultation structure that are most relevant to the patient and to the symptoms that they're presenting with. So just to go through the whole list as a checklist to tick off, that's not going to go down well with the examiners. And so what we need to do is we need to always ask questions that are relevant. I mean, there will be some questions that you'll ask no matter what. You'll always ask past medical history. You know, you'll always ask if they've got any allergies. I think those two go without saying, but I think there are certain questions that it's a bit more open to interpretation, and that will be based on what you're thinking.